Hi, my name is Dr. Lindsay Bissett. I am a emergency veterinarian in North Carolina. And my topic today is going to be the top 10 canine neurological disorders. We're going to go over the first five today, and then there will be five more in my next lecture. So today we are covering vestibular disease, degenerative myelopathy, FCE, brain tumor, and laryngeal paralysis. So vestibular disease is a pretty common presentation, whether it's from an inner ear infection, idiopathic vestibular disease. Those are typically the most common that we are seeing. And typically we're seeing this in older dogs, especially if it's greater than 8 years old. We kind of think idiopathic. So the exam findings is a pretty acute onset head tilt, nystagmus, so the abnormal involuntary eye movement, vestibular ataxia, so a loss of balance. And owners typically come in, they're describing this as kind of like a stroke with the sudden onset and the neurologic symptoms that they are witnessing. So one of the most important things to do on the physical exam is differentiating between peripheral nervous system and central nervous system. So peripheral is by far and large the most common thing that we're seeing. Again, idiopathic vestibular disease as well as inner ear issues. So if it's peripheral, we're seeing, of course, a normal mentation, no postural deficits, and we are only seeing rotary or horizontal nystagmus. We do not see vertical nystagmus in peripheral vestibular disease. That is only seen in central vestibular disease. If it is central, you can also see altered mentation. You can have postural deficits. And although with central nervous system issues, you can see all types of nystagmus, you will only see vertical in central nervous system patients. So further things that we can do to localize the lesion without advanced diagnostics, so just on the physical examination, is the head tilt is typically towards the side of the lesion. Right-sided lesion, right head tilt. Also with a nystagmus, if it is a horizontal nystagmus, you will get the fast phase is away from the lesion. So with horizontal nystagmus, you'll see slow, fast, slow, fast. And for that, the fast phase will be away from the lesion. So if it's a right-sided lesion, you will see slow phase to the right and then fast to the left. And it's called running away from the lesion. And as we already discussed, if you see vertical nystagmus, you automatically know it's central. If you see horizontal and rotary, you have to use other techniques to differentiate between a peripheral versus a central nervous system lesion. Another thing is if the direction of the nystagmus changes with the head position. So if, for instance, it's horizontal when they are in sternal recumbency versus on their back and it turns to rotary, then that is suggestive of a central nervous system lesion. Other things that we can use to differentiate for a cerebellar lesion, you can see a hypermetric gait, so very exaggerated steps or intention tremors, which means kind of when they're at baseline, they will have a very mild tremor, but as they try to move, they start to tremor more and more. And that is common in a cerebellar lesion, which we will talk about her next in my next session. My own personal dog had cerebellar vestibular disease secondary to meningitis, an immune-mediated meningitis. So we'll be talking about her next week, and I'll go over her weird cerebellar symptoms. Horner's syndrome is indicative of an inner ear problem. So it will affect more of the nerves of the inner ear, and Horner's syndrome is defined by three things. You've got ptosis, so the drooping of the eyelid, miotic, tiny pupil, as well as prolapse of the nictitans, so prolapse of that third eyelid. So if you see those things, then that points you to an inner ear issue. Now, something that can trip some people up is the bilateral peripheral. So if it's a dog that has really bad issues with both inner ears, you will not see head tilt, you will not see a nystagmus, but they will still be the kind of vestibular ataxia, still very out of it. And you can tell that their balance is off. They kind of have a very wide head sway, kind of like a crouched gait and posture. So that's something to keep in mind as well. They won't always have that head tilt nystagmus if it's a bilateral inner ear problem. Now, of course, there are always exceptions to the rules. Paradoxical vestibular disease, like with my dog, she had a cerebellar lesion with her meningitis, and which means they don't really follow the rules. The head tilt is to the opposite side of the lesion. So a right-sided head lesion will be going to the left, and the nystagmus is going towards the lesion. The fast phase is going towards the side of the lesion. So instead of the fast phase going to the left, running away from the lesion, with a right-sided lesion, it would be fast phase to the right. So thankfully, this is not very common, but there is something to keep in mind. If the head tilt and nystagmus aren't matching with the postural deficits, that means that leads you to the cerebellar. And you'll just kind of listen to the postural deficits when it comes to identifying if it's a left or right-sided lesion in that case. So when it comes to diagnosis, as I previously said, peripheral is definitely the most common. So ear exam to rule out if they have any issues with their tympanic membranes on exam. And if everything else is kind of pointing to peripheral as well, you kind of are backed into identity of most likely it being idiopathic vestibular disease. Of course, you can't say that without, more advanced imaging to be 100% sure. But most of the time, since idiopathic is self-resolving and it doesn't worsen with time, we kind of get backed into, it being just a diagnosis of exclusion and just giving it a little bit of time as long as the patient is not getting any worse. If you are worried about more significant inner ear problems, like with this poor friend here, you can see that there's on this CT scan, you can see fluid within the bulla. So some pretty significant inner ear issues on both sides of this poor guy. CT scan is going to be great. X-ray, you can see in really significant cases, you can see some lysis of the bulla, but that's not super slam dunk diagnostically to do an X-ray on these guys. To rule out with central nervous system, of course, the best things for that are going to be MRI, looking for an exact lesion, CSF analysis, so looking for excess proteins, cells that shouldn't be there, whether that's neoplastic, immune cells that shouldn't be there, things like that, as well as infectious disease testing. So we're thinking about toxoplasma, neospora, and some other weird friends that like to hang out in the brain. It's always good to rule out hypothyroidism in these guys as well, especially if you're getting, if you're not getting any other results elsewhere. And that's a very easy test to be able to rule out hypothyroidism. Another thing to consider is, very important in history taking, if they've been on metronidazole recently, especially if they've gotten upwards of 30 to 50 mg per kg per day. I've even seen this, one case was actually at an appropriate dose. I had like a 20 mg per kg per day. So it can happen even at lower doses, but typically it has to be pretty high. But these symptoms can mimic central vestibular signs. So history taking in that case is going to be very important. As for treatment, if we're kind of backed into, we were pretty sure this is idiopathic, we know this is going to self-resolve in 1 to 2 weeks, we just supportive care. They're kind of very disoriented, they can be pretty anxious, we can give sedatives as needed as supportive care, meclizine, and so for kind of like seasickness type symptoms, as well as meropitant, anti-nausea medication to help them get over that, vestibular imbalance and nausea secondary to that. If they need fluids, if they're not eating and drinking. The metronidazole toxicity case, diazepam does help them resolve quicker. Inner ear infections, we do need a long course of antibiotics, about 6 to 8 weeks. And if that doesn't help, or if this is a recurrent issue for this patient, then we look at our surgical options, such as the bulla osteotomy and the total ear canal ablation. If it is central, of course, this is treatment is determined by the cause. So neoplasia, which we'll actually be talking about brain tumors here in a little bit, infectious, so antibiotics, depending on the type of infectious agent that we have identified, and immune mediated, so immunosuppression, so with steroids, cytosol, things like that. Again, so if it's an idiopathic, it does self-resolve in about 1 to 2 weeks. Just support them through it. If they're getting worse or if they're not resolving at that point, then you got to dig deeper at that point to look. It's not idiopathic. Otherwise, peripheral, when you have inner ear issues, you can go ahead and treat, and most of these patients do fine, even if they do require surgery. They do end up doing well long term. And unfortunately, the prognosis for central vestibular symptoms is not as good because it's a lot more difficult to treat than our peripheral disease. Next, we have degenerative myelopathy. So typically we see these patients come in when they're a little bit older, about 8 to 14 years old. Most of the patients that I've seen with this, actually, I'm pretty sure all of them, is German Shepherds. They're overly common presenting with degenerative myelopathy. Corgis and retrievers are also on the list of the more common ones that we see with this. So what we'll see is progressive hind limb weakness and ataxia. They'll start with just a little bit of an issue walking with their hind limbs, and then they'll just slowly progress over time. And one of the basic, this is not painful. This is not like intervertebral disc disease where they're very uncomfortable. They just have a little difficulties walking. In the earlier stages, we will see upper motor neuron signs in the hind limbs. So they'll still have their patellar reflexes, still have really good tone, versus later in the disease, they do start to develop lower motor neuron signs in the hind limbs. So you're going to be losing your patellar reflex. You're going to be losing tone. You're going to have some pretty significant muscle atrophy. And it does end up ascending. It eventually starts to affect the forelimbs, their ability to swallow, their ability to breathe appropriately. So fortunately, it's not a very good one to have. Diagnosis is genetic testing. So the cause of it, this degenerative myelopathy, is this SOD1 or SOD1 mutation. And what ends up happening is that they get a buildup of these toxic proteins within their nerve cells that they are not able to conduct appropriately. And even though the German Shepherds, Corgis, and Retrievers are definitely overrepresented, this mutation has been seen in 124 dog breeds and in mixed breed dogs as well. So unfortunately, there is no treatment. It's a progressive disease that we really can't do much for. There has been, it's not going to hurt to give some antioxidant support with things like vitamin E, vitamin C, B12. There's also some people that will start them on protease inhibitors to help break down some of the protein in the nerve cells. It's called, the main one is riluzole. But unfortunately, it doesn't really help or prolong their quality of life very much. Physical therapy can help in the sense that it's not going to necessarily slow down the disease progression, but it will keep their muscles and everything as strong as they can for as long as they can, so they can have a better quality of life long term. And nursing support as things progress in terms of, walking assistance, bladder management, things like that. So this is a poor little dog with absent conscious proprioception there. which we'll see in multiple diseases, but definitely a big sign of general myelopathy in these guys. When it comes to prognosis, as I said, I mean, the progression is inevitable. Long-term prognosis is very poor. They will ultimately succumb and not be able to swallow and breathe, and it's not a fun one. And the big distinguishing factor of it is that they do not have any spinal pain. Fibrocartilaginous embolism, or FCE. These guys are not going to have the kind of chronic progressive like you would see with DM or degenerative myelopathy. This is going to be a sudden onset paralysis. It is also non-painful, but instead of it being, again, being older animals with degenerative myelopathy, we're seeing young and giant breed patients. So Irish wolfhounds, for instance, are overly represented for these guys. And it's usually non-progressive after 24 hours. So if you have a patient that's that you haven't gotten imaging on yet, and it's continuing to progress after about 24 hours, then you know that it is not an FCE. We have something else going on. And because of the nature of it, you can't have asymmetric deficits. So you can't have just one entire side affected and the other side is minimally affected, which isn't nearly as common as like with like a disc. And it is most common in the T3L3 region. So what ends up happening is that you've got we have the nucleus pulposa and the cartilage associated with that, and it ends up sorry, hairball today. The cartilage ends up getting dislodged and ends up going into that vessel there, causing ischemic injury. And you can see it on this MRI here. You see the hyperintensity within the spinal cord here without any actual disc displacement. So diagnosis, of course, is going to be MRI. CT can be utilized, but it's mainly to exclude other causes. It's not going to be as good at detecting ischemic injury within the spinal cord. In treatment, there's really nothing specific. It's just time for that ischemic injury to resolve. Typically, it's not something that persists. You just have to see once that cartilage gets dislodged and blood starts flowing back to that spinal cord, what's that permanent damage that was done to it, or whether it's something that it can actually recover from or not. But in the meantime, some supportive care. So the usual, fluids and whatnot is needed. Bladder management, whether it's an upper motor neuron or lower motor neuron bladder, making sure that they are actually able to urinate. Don't want UTI on top of everything else. And also just basically physical therapy rehabilitation to help keep the muscles and helping the nerves start to reconduct. And steroids do not improve recovery in these guys. And prognosis kind of depends on how severely the injury is to the spinal cord. And just like with disc disease, whether they have deep pain perception or not. So if they do not have any deep pain perception, that's a lot poorer prognosis. So the biggest thing, always consider FCE in sudden non-progressive paralysis in patients that do not have pain. Brain tumors. So typically we see these in older dogs. Median age is about 9 years old and older. The exceptions to these rules, of course, are the more cancer prone breeds, such as the boxer, the golden retriever. And it can be a gradual or a sudden onset, depends on the rate of growth, the inflammation of the reaction to the brain around the tumor, things like that. And seizures are, of course, a pretty common symptom of these. And other signs will, of course, depend on the location within the brain. So when you're trying to localize the lesion, we have, of course, if it's in the forebrain, that's where you're going to be having the seizures. You can have altered mentation, and your proprioceptive deficits are going to be on the opposite side of the lesion. So if it's in your forebrain on the left, they're going to have conscious proprioception issues on the right. The brain stem, so once you get past the forebrain, the cranial nerve and the proprioceptive deficits are going to be on the same side. So left-sided head lesion, you're going to have left-sided deficits. In addition to the altered mentation weakness that we can see elsewhere. And central vestibular signs can also be seen with the brainstem. Cerebellar, we can see kind of as we talked about with the vestibular disease, you will get intention tremors, the hypermetric gait, wide stance, as well as paradoxical vestibular signs. And we got the brain tumor diagnosis. Of course, MRI is going to be the gold standard on that, or a CT scan can also be utilized. It's just not going to be as sensitive. And when it comes to treatment, surgery can be seen as a good option if it's kind of right on the periphery, something that the surgeon can easily get to. Radiation therapy, which can be used in multiple different facets, whether that's palliative or going for a cure. There's also chemotherapy, which can be a bit tricky getting past that blood-brain barrier, but lomustine and cytarabine or cytosar is the trade name for it. And all of those things can be, those two can be used as indicated. And of course, anti-seizure medications, if they are having seizures, we'll talk more about that in my next lecture, and steroids to reduce inflammation associated with the tumor as well as the surrounding brain tissue. Prognosis is fair to guarded with treatment. It depends, again, how readily we are able to get to that tumor surgically with radiation without causing too much damage. If it's untreated, on average, we're looking at about 2 to 4 months from the onset of symptoms. Now, we always do want to keep in mind kind of this age cutoff for new seizures in our pets and our patients that we're seeing. The most common cause of new seizures is going to be neoplasia in dogs that are greater than 6 years old. If they are less than 6, then we are thinking idiopathic epilepsy. More likely. Of course, we can't definitively say that without more advanced imaging, but in general, greater than 6, tumor, less than 6, idiopathic being the most likely causes. Some other kind of, general guidelines. If we're looking at long-nosed breeds, such as the golden retriever, you're more likely going to be seeing a meningioma versus short-nosed like the boxer, we're most likely going to be seeing a glioma. And our last one for today is laryngeal paralysis. Now, when we're seeing these patients, unfortunately, most of the time, this is not going to be a standalone issue. We are going to be seeing it as a complex with GULP. So geriatric onset laryngeal paralysis and polyneuropathy, which we'll talk about in a couple of slides. Typically, we're seeing this in middle-aged to senior large dogs. So labs are definitely overrepresented. St. Bernards are, this can also be seen. As for the symptoms, we're not seeing stridor, like the bulldogs, the in their nose. You're hearing the stridor kind of within their throat. Another common thing that you'll hear owners say is that their bark has changed. And they commonly cough after eating and drinking because they cannot properly protect their airway, as well as exercise intolerance. Pets that used to be able to, go miles and miles can, barely go a half mile. And we may They may present in acute respiratory distress. So it could be something that, they come into a general practice and are like, hey, they're kind of breathing kind of weird. Or they can come in true distress where they really cannot get any air, through their airway at that point because it's so collapsed. There's so much swelling and secondary edema. We also, if they do come in respiratory distress, we do want to make sure that we are ruling out aspiration pneumonia as a cause for their respiratory distress. Again, because they cannot protect their airway, aspiration pneumonia is a common consequence in these guys. So to get a definitive diagnosis of laryngeal paralysis, you are going to need to do a lightly sedated laryngeal exam. If they are too heavily sedated, then they're not going, even if they have a completely normal larynx, they're not going to have as good of control of their airway. So light sedation is the best way to truly rule this in or out. And this can be unilateral, so just one side or both sides can be affected. So chest x-rays to rule out for aspiration pneumonia, as well as megaesophagus. So in that gulp syndrome that I initially mentioned, megaesophagus is a common thing that we can see with these laryngeal paralysis patients as well at some point. And so, and also again, ruling out hypothyroidism. So when it comes to treatment, they're in an acute crisis, of course, oxygen, sedation, steroids to help with any swelling. And ultimately, depending on how severely affected they are and how affected they are otherwise in the gulp syndrome. So if they concurrently have megaesophagus and things like that, you got to take all of those into consideration. But surgery can be done with a unilateral or retinoid lateralization or a tieback, taking one side of the larynx and pulling it and tying it to the side so they don't have acute collapse. Unfortunately, about 35% of these patients post-op do develop aspiration pneumonia. So before they didn't really have very good laryngeal control to protect their airway, but now you've tied one side completely back. So unfortunately, aspiration pneumonia is very common in these guys, especially if they have no other neurologic deficits. So if they've already developed megaesophagus or hind limb weakness from this gulp syndrome, then we know that they can have upwards of 75% of a complication rate. So it's very important to educate owners before pursuing this type of intervention and surgery. Non-surgical things that can help: weight control, so they don't have all of that fat hanging around their larynx, as well as limiting their exercise and no neck collars. Make sure they have a harness. Laryngeal paralysis with in terms of how it progresses. So unless it's laryngeal paralysis pretty uncommonly just stays is the only issue. Typically within a year, they're going to be progressing, whether that's, megaesophagus or, even just a small degree of esophageal dysfunction and hind limb weakness and paraparesis, generalized muscle wasting. So again, making sure that we are educating these owners that this is always a possibility. So biggest things to take away is being able to differentiate between a peripheral versus a central vestibular disease patient. And keeping in mind that between degenerative myelopathy versus an FCE, they are both non-painful, but degenerative myelopathy is a chronic progression versus an FCE, which is acute onset paralysis. For new onset seizures, patients that are greater than 6, think tumor; less than 6, think more likely idiopathic. And that laryngeal paralysis is typically a part of the gulp syndrome, and they do have high complication rates associated with that. Okay. Thank you for your time.